Hi, everyone. It's good to see everybody. I think we'll get started if Dr. Paruk is ready. I see you now on video. I'm Michelle Durham, one of the associate directors of our Global and Local Center here at BU School of Medicine. I'm a psychiatrist and the vice chair of education in the Department of Psychiatry. I have the great pleasure of introducing Dr. Saeeda Paruk, who is a child psychiatrist and conducts research focused on early onset psychosis in children and adolescents, and has several publications and co-authored book chapters on child psychiatry for the South African Psychiatry textbook. She's presented locally and internationally at meetings and was the first child psychiatrist in KwaZulu-Natal to be awarded a PhD. She is currently supervising several master's and PhD students' research projects based on assessing the impact of HIV on people with early psychosis, the impact of COVID-19 on psychosis and services, and the SIDEMAP study. She's received the UKZN MEPI funding for her PhD, the Biological Psychiatry Established Researchers Award, an NRF Award, and MRC for funding for her research. She also co-coordinates the Discipline of Psychiatry Research Program to nurture and develop emerging researchers in mental health. It's been a really rewarding experience for her. We've gotten to collaborate with Dr. Paruk and as well as others at UKZN, and have been very lucky to have their collaboration on many research projects we have here at the institution, here at BU School of Medicine. So with that, we're really, really happy that you could speak today, and I'll let you take over.
Thank you, Michelle. Thanks for the very lovely introduction. Doesn't quite sound like me, but
well, yes, because we also know you're quite humble, but it's nice to say all that out loud.
Thanks, Michelle. So I'd just like to thank Boston BUMC department and Professor Henderson and his team for inviting me and giving me this opportunity to speak to all of you today. And I'm going to be speaking on a subject that is a little bit easy for me because we're talking about new onset psychosis research, which is something I've been involved in for a while. So I think it's easier to talk about something you're familiar with. I'm going to just share screen. So please feel free to just unmute and ask a question, etc., if you want to. And I will definitely allow for time at the end to have a discussion as well. So the brief for today was to discuss our research experiences on first episode psychosis and give you a perspective from KwaZulu-Natal, South Africa. And I just wanted to firstly fill everyone in as to a little bit about what we're going to talk about. And so I'm going to focus a little bit about where KwaZulu-Natal is in South Africa, in case some of you may not know. A brief definition on first episode psychosis, and then focus on two projects that I have been involved in. One being an early onset psychosis project that looked at adolescents with psychosis. And then a second project that is looking at the association of HIV and first episode psychosis amongst adults. So some disclosures are that the studies that I will be discussing have been funded by the National Research Foundation of South Africa and by a South African Research Council grant and a Biological Society grant. So South Africa is on the most southern tip of Africa. Some of you have been able to visit us, but for those who haven't, our neighbors include Namibia, Botswana, Zimbabwe, Mozambique, and we also have a little landlocked country called Lesotho right in the middle of our country. South Africa, like in the States, you have different states. We have provinces, and we have 9 provinces. KwaZulu-Natal is on the east coast. It's the one in yellow on your picture with all the little towns in it. And it's on the east coast of South Africa. It's about the size of Portugal, if you have to compare it to another country in Europe. And it has a population of about 11 million people. So the second most populous province in the country. We have beautiful beaches. This is our hometown with Durban, which has the lovely beaches. So hopefully many people are going to want to come across. And it's a very picturesque province. And if you drive inland, you come across the Drakensberg Mountains, which is about 3 to 4 hour drive from the city. This is our medical school. So the lovely fancy building is new, and it's a research center funded by a lot of US funding for HIV research. The smaller plain buildings behind the tree are actually our old medical school, which is where we did our undergraduate and postgraduate training. It was also one of the very few medical schools in the country for non-white students in the apartheid era. These are some of our clinical sites, which are also our hospitals, and we do the clinical research based at the different hospitals. So the first picture is Addington Hospital, which is literally on the beachfront. It occupies prime property with the hotels. This hospital runs a 24-hour psychiatry service and is manned by 2 full-time specialists and a 20-bedded unit. It's currently one of the sites where we are doing the FEP HIV project. On my right is a picture of King Edward Hospital, which is one of our regional hospitals and attached to our medical school. It also has a 20-bedded psychiatric unit, and it has 3 full-time psychiatrists. And the picture on the bottom is a picture at Prince Mshini Hospital, which is in Umlazi, a township. And here, like in all the other hospitals, this picture illustrates some of our challenges in the state hospitals, where we have very long queues, lots and lots of patients, having to often coming from as early as 5 a.m. in the morning so that they can pull out the records, see the doctor, stand in another queue for medication, etc. And many of them rely on public transport, which is not really very good, to go and come from the hospital. So it can be quite a challenge to get to a hospital. So a little bit more about KwaZulu-Natal. So in addition to the beautiful scenery, and we have a lovely tropical climate, winter is generally 18 to 21 degrees Celsius on the worst days. So lots to look forward to, but also at the same time, many challenges. We have high rates of poverty. At least 50% of the people live under the poverty line, high rates of unemployment, poor access to mental health care. To illustrate that, we have 3 doctors who are working in child psychiatry for the province. So most children or adolescents will not get to see a child psychiatrist ever. And also referral pathways, etc., are complex, and therefore access is really difficult unless you're really very sick. We also still have high rates of trauma and violence in our society, and the inequality and economic disparities of the past haven't been adequately addressed yet. In addition to that, over the years, we've now become the hotspot for HIV. KwaZulu-Natal is the hotspot in South Africa for the HIV epidemic. Substance use rates are increasing. We previously traditionally had mainly alcohol and cannabis use in our population, but over time we are seeing increasing use of opiates and methamphetamine as well. And in 2019, we added on the COVID-19 pandemic to our woes. So we now also have the economic and psychosocial and biological challenges of the COVID-19 pandemic to deal with in our healthcare system. So against this kind of backdrop, at our psychiatric hospitals, we have very limited beds, and the patients are often waiting to get a bed at the hospital. So often it's the most disruptive, the most aggressive, the most ill patients who get referred through the system. And that's why we have a lot of patients who are severely psychotic, who are requiring a lot of intensive care. And this is what I think made me more interested in looking at psychosis, because we were dealing with so much of it in the hospital. And I thought it was important for us to be as best as we can in trying to manage these patients. The other challenge we have is HIV. And in 2020, the global prevalence of people living with HIV was estimated to be approximately 38 million people. And of this 38 million, about 8 million of them are living in South Africa, making the country the epicenter of the epidemic. And as I said, KZN, KwaZulu-Natal, is one of the hotspots for the HIV infection in this country. Living with HIV has been linked with higher risk of mental illness, and particularly with psychosis, there's thought to be a bidirectional association in that people with psychosis are more vulnerable to HIV, various different mechanisms, and those with HIV are more likely to develop psychosis than the general population. So this was kind of the basis from which some of our research has developed. So just to start afresh on psychosis, the definition of first episode psychosis varies depending on different sites and different research projects. Some people use a very narrow definition of first episode psychosis occurring within the first 6 weeks or first 12 weeks. And then some people get more broader, the first year, and then there are now people who define first episode psychosis up to the first 5 years. And it's thought more recently that Miller et al. Suggested that anybody presenting with onset of psychosis within the first 2 to 5 years be considered as a first episode psychosis individual. And then more recently, it's also been suggested that rather than using the term first episode psychosis, we should rather say new onset psychosis, which may be a better reflection of the process in these individuals. I think whatever terminology you use, whatever definition you use, the most important thing is that this is a very critical period where we could possibly intervene and alter the long-term outcome in patients with chronic psychosis eventually. And so for me, I think that is the important point in trying to understand first episode psychosis better, that hopefully with better understanding will come better intervention. Early onset psychosis, being a child psychiatrist, I was naturally also very concerned because we had lots of teenagers coming in with psychosis. And unfortunately, in our setting, the teenagers get admitted to adult wards because we don't have proper adolescent facilities for them. We are hoping to open one in the next few months, but for now, we are using the adolescent patients going into adult wards in most hospitals. So early onset psychosis is defined as the development of psychosis before the age of 18. And very early onset psychosis refers to psychosis onset before the age of 13. Loranger et al. Suggested that approximately 40% of males and 23% of females have onset of schizophrenia before the age of 19. So a significant proportion of patients with a chronic psychotic disorder will have an early onset. And since adolescence is such an important developmental period, with so many important changes, particularly in terms of identity development, social cognition, etc. Disruption of these processes at a critical period is associated with significant emotional, cognitive, and social functioning impairment and disability. And therefore, my interest in early onset psychosis and first episode psychosis. So I'm going to first talk a little bit about 2 small projects we did looking at patients with early onset psychosis. The first project was a very small chart review that we did some years ago, almost 10 years ago now, which looked at the profile of adolescents who were admitted with psychosis. And over a 2-year period, we admitted 70 adolescents with primary psychotic problems to our unit. All these individuals were admitted to an adult ward and managed by general psychiatrists generally. So over that 2-year period, we found that 80% of the adolescents admitted were male. At least 1/3 had a positive family history of mental illness, and 61% reported cannabis use prior to admission. This was quite important for us because it seems that cannabis use is an important risk factor in our setting. In South Africa, we still have to use a first-generation antipsychotic before moving on to a second-generation antipsychotic. And as this study was some time ago, 85% of the adolescents were given a trial on a first-generation antipsychotic. They may have been subsequently moved to a second generation, but 15% were initiated on second-generation antipsychotics de novo. Also, many of these patients come in from peripheral hospitals, which may not have good access to second-generation antipsychotics. So hence they do start off on a first generation and then we do change them over. What was also very concerning was that over 40% of these patients defaulted follow-up after discharge. So we had a very high rate of patients not coming back for follow-up. And this at a critical period in their lives, it really is concerning. And we don't really have good early intervention or first episode psychosis programs at the time. So from that study, we also looked at the data. So there were 70 adolescents admitted with psychosis, but 45 of them had first episode of psychosis in that particular group. And when we looked at the data relating to only the 45 adolescents with first episode psychosis, we found that whilst there was still a significant high prevalence of cannabis use and a high prevalence of patients who had a positive family history of mental illness, cannabis use was associated with an earlier age of presentation and a longer duration of symptoms prior to diagnosis. There were no correlations in this sample between family history of mental illness and other variables. However, it was a very limited study because it was retrospective chart review. So we relied on note keeping. It was a small sample size, etc. So from here, we moved on to we thought let's do a prospective study. So we then moved on to do a cross-sectional study of all patients between the ages of 12 and 18 admitted with the first episode of psychosis at 3 public hospitals in Durban, KwaZulu-Natal. In this study, we assessed the patients with the PANS Sociodemographic Questionnaire, a symptom onset in schizophrenia questionnaire, which was used to assess duration of untreated psychosis, and a substance use questionnaire. The mean age of the participants who were admitted with first episode psychosis was 15.9 years, and 69% were predominantly male. What was quite interesting was that almost approximately over 40% of the patients and their parents reported no prodromal symptoms at all. They felt that the patient had an acute onset of psychosis, and often the duration of untreated psychosis reported was fairly short, and the mean in this study was 27.2 weeks. I'm not sure whether sometimes this was a subjective reporting because families were concerned about being stigmatized or doctors being upset with them for not having brought in the children earlier. So this was the initial profile of the patients. And we then looked at what was the association between cannabis and first episode psychosis in these adolescents who are presenting to us. So 55% of the 45 adolescents had reported lifetime cannabis use. And many of them reported use before the age of 14. In fact, mean age of first use was 13.9 years. In this particular study, we found that cannabis use was associated with greater total and positive PANS scores in terms of current use and lifetime use, but not with negative scores. DUP was only marginally influenced by early exposure to cannabis use, but not by lifetime or current use of cannabis. So it was a small study, but it did suggest that cannabis use may be impacting on the age of presentation and the severity of their symptoms. So some of my reflections after having completed that study were that in that particular study, we had excluded HIV because we had wanted to collect a sample that had primary psychosis and was not confounded by other medical conditions such as HIV or epilepsy or head injury, etc. But I also realized that it was important for us to consider what was the impact of HIV on the clinical presentation of psychosis. In that study, besides, I described the profile of the patients with psychosis, but we had also compared the adolescents with psychosis to adolescents with a non-psychotic illness for substance use. And it was very difficult to actually recruit the non-psychotic youth because the psychotic youth get referred to us for admission because they're disruptive, they're aggressive, they're hallucinating, and the teachers or the family would like them to be assessed and get treatment. However, with non-psychotic youth who are depressed or anxious, unfortunately, they often go under the radar, are missed by the healthcare system and education system, and do not get referred to us. So in the end, actually, I was battling to find non-psychotic youth that could be matched to these psychotic youth for age and gender. Again, illustrating the need for better healthcare, we have subsequently drawn up a screening questionnaire for primary healthcare clinics to better identify depression and anxiety amongst the youth. It was also quite concerning that parents and patients denied prodromal symptoms, whether these were not there or whether there was very subjective reporting of early symptoms. Needs further clarification. The study also illustrated for us that duration of untreated psychosis varied, and possibly that varied because we had such varying pathways to care in our study. 40% of the youth first consulted a traditional or faith healer prior to seeing a medical doctor for their psychosis. So this again illustrated the need for us to have more integration and consultation with the traditional healers so that people can better identify psychosis and we can work collaboratively. Also, these were cross-sectional studies, so they were limited in their ability to look at causality or to look at outcomes. So we recognized that there were several limitations to the work we had done, and we then started looking for a new project. So this time we've decided to do an adult onset first episode psychosis study and to look at it in terms of its association with HIV, because both these are are big public health concerns for us. So HIV has been around for some time now. I think I'm going to give away my age, but when I was a young intern, HIV was new and we were learning to deal with HIV and there were no antiretrovirals at the time. And then as early as 1998, people began reporting new onset psychosis in individuals with HIV/AIDS. And this is an article which was a case report of a new onset psychosis in a patient with AIDS. Subsequently, over time, Alicati and his team reported the presence of new onset delusions and hallucinations in individuals with HIV. And they reported that there is possibly an increased risk of these symptoms in individuals with HIV, and that we would need to keep this in mind as we treated patients with HIV. And they suggested that the most likely reasons for this onset of psychotic symptoms was on the basis that HIV caused cerebral opportunistic infections or metabolic encephalopathies or a delirium. Thereafter, Dalder and colleagues in 2004 did a systematic review of the literature on new onset psychosis in HIV disease, and they suggested that there was an elevated risk of psychotic disorders in individuals with HIV. And they thought this risk increased with age. Then in one of the first articles to actually describe the psychopathology of psychotic symptoms in HIV-positive individuals, Deronki and colleagues did a small study which looked at 22 individuals with psychosis. Some were HIV positive and some were HIV negative. And they used the BPRS, the Hamilton Depression Scale, the Hamilton Anxiety Scale, and Mini-Mental. And they showed that patients who were HIV positive and had first episode psychosis had more severe psychotic symptoms and greater anxiety and depressive symptoms, and also greater cognitive deficits in the areas of attention and concentration compared to HIV-negative individuals. So this was one of the few studies that actually went and looked at the psychopathology and compared it to those without HIV. Then Bolton and Attard in 2009 also compared those with HIV and psychosis to those with psychosis and no HIV, and reported that obviously the prevalence was much higher, 15% in patients with HIV and who then developed psychosis, compared to 1% of the general population that developed psychosis. They also noted the changes in psychotic symptoms, cognitive deficits, that these patients were more difficult to treat, required longer-term antipsychotics and higher and lower doses because of the propensity for EPSE. Subsequently, a study from Africa, Uganda, by Professor Nakasuja and her team compared patients with psychosis. They were not necessarily first episode psychosis patients, but they compared patients, 156 patients with HIV to 322 patients without HIV who were all living with psychosis. And in their study, they again showed that patients who were HIV positive had greater cognitive deficits at baseline, bearing in mind that this study was done when there was not lots of ARTs or antiretroviral treatments available in Africa for all patients. So only some of them were on antiretrovirals. And even after the psychosis was treated, so on follow-up, those who were HIV positive, although they improved, their cognitive impairment was still more than the HIV negative group. So it was felt that cognitive impairment in psychosis was worsened by comorbid HIV infection. Subsequently, there have been quite a few reviews by Nebanani et al. There's also been one by Brewer et al., etc., which reviewed mental illness or psychotic disorders with HIV infection. I used this article because they suggested that between 3 and 23% of patients with psychotic disorders were HIV positive, and that psychosis occurred in 0.23 to 15% of patients with HIV. Okay, so obviously a bidirectional association and much higher than in the general population. Helleberg et al. Also confirmed this, suggesting that individuals with HIV had a 2 to 4 increased risk of developing schizophrenia compared to HIV negative controls, and a 4 to 7-fold increased risk of developing psychosis, with psychosis risk being the highest during the first 12 months after the diagnosis of HIV. So then there were subsequently articles again emphasizing the need to look for psychiatric comorbidity in people living with HIV. And we then did a small chart review looking for comparing individuals with HIV to those without HIV who were admitted with psychosis to our unit in Durban. And we noted that whilst generally the number of people admitted with psychosis is often a male predominance, the number of females who had HIV and psychosis was higher than the number of males. And this is in keeping with our females having a greater vulnerability to HIV in the community as well. Those who had HIV and psychosis were more likely to be younger, have less secondary education, and more likely to have comorbid medical disorders and hematological abnormalities compared to the HIV negative group with psychosis. Interestingly, in our studies, the HIV positive group did not have an increased incidence of substance use. This was borne out in a few studies. There was a study by Meshapu et al., which looked at the prevalence of HIV in a hospital in Pietermaritzburg that found a very low prevalence of substance use in the HIV group. In this study by Mere et al., and then also in a more recent study by Bengu et al., which looked at a young woman in the first week postpartum, the HIV positive group did not have higher substance use compared to the HIV negative group of young women. So possibly, often cannabis or other substances are thought to be the drivers of maybe more disinhibition and then resulting in HIV in patients with psychosis, but this is possibly not the case in our setting, but it needs to be explored in larger longitudinal studies. So we then also had a more recent study from Gauteng, South Africa by Lahare and team, which reported a very high prevalence of HIV amongst their patients with first presentation of psychosis. They reported an almost 40% prevalence of HIV amongst first episode psychosis patients. So we were wondering whether ARTs and all the HIV prevention programs were making a difference for our mentally ill to some extent. Then a very interesting study from Denmark by Helleberg and group again. And in this study, what was quite interesting is that they did a huge population-based cohort study to look at the risk of schizophrenia after a diagnosis of HIV and the risk of HIV after a diagnosis of schizophrenia. And interestingly, they noted that HIV was associated with an increased risk of schizophrenia and acute psychosis. But schizophrenia was not associated with an increased risk of HIV if there was no substance use and if the individual started ARTs. So possibly that risk of HIV in patients with schizophrenia may be modified if we can address substance use and provide ARTs early. So we then went back to looked at all this literature. We've just recently published a systematic review and meta-analysis on the dual burden of HIV infection and first episode psychosis based on the studies from Africa. And there were very few studies. And based on the studies that were available, currently our estimate was that there was that the pooled prevalence of HIV in first episode psychosis is around 26%. And the risk of people with HIV developing psychosis ranges from about 17 to 29% in the different studies that we had. So we've now begun our own study. This is our study protocol. It's investigating the impact of HIV on patients with first episode psychosis. It's a longitudinal cohort study which sees the patients at baseline when they present treatment the first time within 6 weeks of antipsychotic initiation. And we then follow them up at 3, 6, and 12 months. The aim of the study is to compare the socio-demographic, clinical, trauma, and substance use and cognitive profiles of patients with first episode psychosis with and without HIV. As I said, at baseline, 3, 6, and 12 months. It is a longitudinal quantitative study, and we are hoping to recruit 130 people living with HIV and psychosis and 130 people with psychosis alone from 5 clinical sites in the eThekwini region. Our inclusion-exclusion criteria are essentially patients with first episode psychosis between the ages of 18 and 45, whose HIV status will be confirmed by an ELISA test and who are within the first 6 weeks of antipsychotic initiation. Some of these criteria, because we are also doing a neuropsychological battery on them. This slide is not easy to see, but some of the tests we're doing are physical examination, neurological examination, a PANS test, a PHQ-9 for depression, a PTSD scale, trauma scale, substance use scale, quality of life scale, blood test for HIV, viral load, and CD4 counts. And then if there is neuroimaging or other blood tests available in the chart, we include those. And then the patients are seen 4 times in the 12-month period. Our cognitive assessment, we chose not to go with the matrix because patients in Africa tend to score much lower on the matrix compared to possibly US participants, etc. And we don't really have good norms for them in our population. So we opted to use tests that we have some norms for and therefore can make comparison to the general population. We have also included a social cognition element to the study and currently are using the FACES test, the EYES test, and the situations test, situational context test. Possibly the hinting task is something we missed and should have included. So we've been recruiting from late 2019. Unfortunately, we had COVID, which made us suspend the study for about 8 months. But we've currently recruited 113 first episode psychosis patients who are HIV negative and 35 first episode psychosis patients who also have HIV. Follow-up has been challenging. I think follow-up is generally challenging in patients with psychosis and became more challenging with COVID and patients' reluctance to come back, and also, with having to suspend the study for a while. Thus far, we've encountered quite high rates of substance use as a comorbidity and also significant reports of childhood and adult trauma. We did a preliminary analysis of participants when we had 60 participants, and I think this was done for a presentation by one of our PhD students. There was a predominance of males in the sample, and 68% of the participants had a household income of less than $277 per month. And what was quite interesting was that 68% reported experiencing some type of lifetime trauma. 15 of the 60 patients were HIV positive in that first cohort, and 11 of them were on ARTs at the time, and we subsequently initiated those who were not. Only 6 of the 11 patients who presented initially were virologically suppressed. So again, the HIV care was also not optimal in these patients. This just reflects some of the PANS, the HIV prevalence, and the lifetime substance use. As you can see, high rates of cannabis use in the study. 25 of the 40-odd males had substance use. The PANS scores. The PANS scores did not significantly differ based on HIV status, but they did differ based on a trauma, childhood trauma questionnaire. We then looked at the participants again when we had 97 participants. Again, a very similar pattern, preponderance of males. However, we found that the females were much more vulnerable to HIV. While the male to female ratio is 1:2 for psychosis admission, it's like females are more likely to be HIV positive with a ratio of 2:1. 24% of the individuals had psychosis and HIV thus far, DUP varied, and IHDS scores and PAN scores were lower for females who had HIV compared to females who did not have HIV. Again, with the 134 participants, we had very similar results, and we did not have any statistically significant findings for HIV status amongst males, but the females with HIV scored much more poorer, both on PANS and on cognitive assessments. So reflections are that it appears that females with psychosis appear to also have more likely to have HIV in our study. This requires us to go back and look at more focused programs to address this. We had high rates of substance use, high rates of trauma, and very poor follow-up and adherence. Therefore, reflecting the urgent need for first episode psychosis programs that specifically focus on these individuals in the community. By no means is the work that I've been involved in the only projects that are being done in KZN in first episode psychosis. Prof. Burns has done a lot of work on first episode psychosis. And so if you want to look up somebody who's work on duration of untreated psychosis and pathways to care, then I would suggest him as a good reference. We have a new study called PsyMap, which is a study that's funded by the MRC, and it's a collaboration with several partners, including Prof. Bova from Boston and Prof. Burns from Exeter now, with Prof. Kalisa as our PI from UKZN. This is a study looking at the incidence of psychosis in a community sample. So it's going to be really innovative, and we've just begun recruitment, and I think they've recruited their first 20 patients thus far. We are looking at a new study called Rematch, where we are hoping to take the present cohort of patients we have with first episode psychosis and follow them through the pandemic to see how the pandemic has affected individuals living with psychosis. So fingers crossed, we're trying to get a bit of money to do that. There's a lot of good work also coming from Stellenbosch, Prof. Emsley, Prof. Kalisa was based there previously. So they have a very strong first episode psychosis research unit, which does some wonderful work on various aspects of first episode psychosis, also particularly looking at things like cognitive batteries, neuroimaging, etc. Yeah. So I think at the end of the day, as clinicians, trying to understand first episode psychosis is important, because if we better understand the risk and prognostic factors, then hopefully we can provide more meaningful interventions. There is a lack of interventional studies across the board, and we have just begun one interventional study now where we're taking a cohort from our FEP HIV study who have first episode psychosis and PTSD, and are looking to provide them with a trauma intervention to hopefully help them address the often neglected PTSD component of their illness. So yes, there are many challenges, but there are also lots of opportunities for researchers to explore in the field of first episode psychosis. Thank you for your attention. Any questions?
Thank you so much for a wonderful presentation. There was one question in the chat that I don't think you may have gotten to, so I'll just ask it out loud. Do you think the high rate of cannabis use might be the cause of no prodromal symptoms?
Thanks for that question. I think that's quite relevant, that sometimes because teenagers are using cannabis or other drugs, parents may attribute the change in behavior to the substance use. And that may also be why we're finding that adolescents with substance use tend to come in later, because parents may be hoping that this phase of their teenager's life will settle somehow and do not bring them in for treatment earlier. Or they may be going to rehab centers, etc., and being missed in terms of their psychosis.
Are there any other questions? Oh, I think Dr. Wusu has one, but she wants to wait a second. There's noise in the background where she is.
We had a storm in Durban this afternoon, but fortunately it settled just before the talk.
Oh, good.
Sometimes the Wi-Fi goes down.
All right, sorry about that. There's just an overhead sound. Thank you so much for the presentation. I am curious, just based on things I've heard anecdotally, my family's originally from Ghana, and there's kind of lore in Ghana that Ghanaian people are maybe more susceptible to the psychogenic properties of marijuana than other people are. And I have no scientific information to base that on. But I am curious if in your research on first episode psychosis and the correlations with cannabis use, if you've noticed any comparison between the populations that you've seen on the continent versus populations in other places, and if it's equivalent across the globe, or if you've noticed any differences, and whether that relates to the type of cannabis that people are smoking or to genetic susceptibilities.
So, the cannabis debate about whether cannabis causes psychosis, etc., was raging for a long time. And where they used more potent cannabis, then they saw the psychosis earlier. And I think initially in the East and in Africa, we were reporting psychosis associated with cannabis, whereas the West, which was possibly using it more as a recreational drug and low potency, did not really have that experience. But with time, as the synthetic cannabis and the potency of cannabis got better globally, I think everyone now agrees that you're seeing very, very sick individuals who, especially if they've had a biological vulnerability to psychosis, these individuals can get quite sick. Obviously, the potency of the cannabis use makes a big difference. And unfortunately, the aim is to create more potent THC products because the better the high, I suppose. So often you can have many patients who smoke cannabis for many years and it doesn't affect them. But obviously, if they have a biological vulnerability and they have high potency cannabis, it also depends on the frequency of the use. It's also thought that the earlier the use, etc., could all impact on the eventual presentation of the patient. The other interesting thing is that there is a compound. So, cannabis has more than 60 different cannabinoids, and obviously cannabidiol may have some psychotic protective, antipsychotic type properties. It's still being investigated further, but whether, the balance of that could also make a difference sometimes in some groups, depending on what they're using. So in Durban, we have a thing called Durban poison, which is supposed to be more potent cannabis, but I think now the synthetic cannabis that's produced elsewhere is much more potent than what we produce.
I have an unrelated second question, but I'm happy to let someone else go if anyone else has another question. All right. My other question is just as your experience, I think you mentioned that you're one of 3 child psychiatrists in your area. And you kind of mentioned the threshold to get someone to child psychiatry is quite high. I wondered what is that threshold? Who are the patients that do reach you when there's so few child psychiatrists?
So what happens is all psychiatrists see children in our country. It's part of our general psychiatry training. In fact, even in part of our undergraduate training. So even as a medical student, you'll get exposure to some child psychiatry, because we would like everyone to be able to assess and treat at least whatever they can, because they may be working as doctors in primary healthcare clinics, etc. And then all our psychiatrists have training in child psychiatry, so they see a lot of the patients. Also, we have good collaborations with the pediatricians. So, for example, I run 2 clinics with pediatricians during the month, so that patients that they are having difficulty managing, we co-manage, etc. But I think, so obviously children who are psychotic or who are disruptive or who are suicidal, those patients get referred through because it's picked up and people are not sure what to do, so those patients will come through. But unfortunately, if you're quietly depressed or anxious and you're not bothering anyone, then the chances of you being screened and referred on are much lower. I'm not sure what your experiences in Ghana are like.
Yeah, quite similar. There are no truly formally trained child psychiatrists. There are maybe a few who've done master's level programs that maybe more of a population health perspective. And I'm a child psychiatrist here in the US, and I would say it's probably pretty similar. More depression and anxiety probably make it through to actually see us. I definitely have plenty of depressed and anxious kids in my panel, but I would say those who are really behaviorally dysregulated are the most likely to make it through.
Yeah, the conduct disordered child will present always, but unfortunately we don't get to see all the depressions and anxiety, and that's sad, because I think it also kind of skews people's impression of child mental health problems. Sorry, Michelle, we went on a bit of a tangent.
No, that's okay. Everyone else is enjoying it, I'm sure. We are out of time. We want to thank you, though, for your wonderful presentation, such an important topic, not only there, but here as well. So thanks again. I want to thank everybody for joining today, and be on the lookout for emails for our next global lecture. Hope everyone has a wonderful day, and you've gotten lots of accolades in the chat, Dr. Paruk, so don't forget to look at that as well. People really enjoyed your presentation.
Thanks, Michelle. Thank you so much.
It's always good to see you. See you soon.
Thanks, Michelle. See you soon. Thanks, everyone.
Bye, everybody.
Have a good day.
You too.